you doing today? Everyone is super excited. So yesterday you left everyone with leaving for much more. So today everyone is back to for your session, and we all know Dr. Thomas Lodi has come up with he's going to be explaining about newer therapies in the management of cancer. And without any further ado, I'm going to leave the stage to you. Let's start off the session. Thank you. Thank you, Dr.
Thank,
Lodi.
thank you so much. I just want to say that my favorite place in the world, my favorite people in the world is India. Um, it's the only place that where I am, that everybody seems to get it. Everybody, all the things that you have to explain to the rest of the world, Indians already know. So I love it. So anyway, yeah, I was there, as I told you, in 1971, spent a couple years on an ashram, and anyway, my heart's still there. And I'm pretty sure that my ancestors were the kings of India at one point, right? The Lodi kings. So anyway, let me share this and let me get started. All right. So let's join the resolution, not the revolution, and let's resolve CFCs. Now, if you remember from yesterday, we're not going to use that word. We're not going to use the zodiac symbol. Was it Sagittarius? What is it? Aquarius? What are we calling it now? Anyway, I'm pretty sure if you do any surgery, you're not going to find any zodiac signs inside anybody's body. Okay, so that's the only definition of cancer is a zodiac sign. Okay, it conveys no information. Chronically fermenting cells, right in line with Warburg, right in line with Siegfried, right in line with the truth. So let's go from there. Okay, now, acute fear and cognitive shutdown, very, very important. Acquiescence, giving up, saying okay. Okay, so with acute fear, cognitive ability is severely impaired, right? And you become acquiescent. You become submissive and compliant. Why? Because you are overwhelmed with fear and you just think that whoever's talking to you is going to give you the answer and you just give in to it. So you become compliant and you don't critically think. And so you accept what's happening. This happened when, and you got to be aware of words. Please be aware of words, okay? They are so important, and don't use words that don't exist. For example, if there's not a pandemic, don't say there's a pandemic. If there's not a vaccine, don't say it's a vaccine. Don't use their words, because then you're in their video game and they're going to win. All right, get out of their video game, okay? Now, cognitive shutdown, we know that happens. We know that happens pretty much because of the acute stress response. And we're all familiar with acute stress response, right? Goes right through the hypothalamus, it knocks on the sympathetic system, and the pituitary starts the whole adrenal process, where we have epinephrine, we have norepinephrine, we've got cortisol, and we've got everything shunted away from our organs so we're completely changed. What else goes down with the acute stress response? Immunity. Immunity goes down because it's not important right now. I got to get away from that guy with the gun. And what else goes down? Cognition, because I can't say, should I run left or should I run right? Or I'll be dead. I have to just respond. So we get rid of the prefrontal cortex. It's no longer involved, all right? And we know that fear starts in the amygdala, and it goes through the hypothalamus, and there we go. And then it connects to the prefrontal cortex and all that stuff. Anyway, all that is shut down, okay? So our decision-making ability is gone. So my question is this: am I capable at that point of... And the answer is no. Now, what does acute fear do to immunity? Knocks it down. As we said already, cortisol, epinephrine, all those things we know shut down the immune system. We know that, okay? But so in acute fear, what do we see? We see reduced T cell proliferation. B cells are no longer turning into plasma cells, no longer producing antibodies. Macrophages, who are the bridge between the innate and the adaptive immune system, get knocked down. So do the dendritic cells. Neutrophils increase, so we wind up getting an increased NLR, which I'm sure you all know about that. A neutrophil to lymphocyte ratio of greater than 5, very poor prognosis. Less than 2, good prognosis. Okay, why? Because we're really turning on the acute inflammatory versus the healing. All right, and NK cells are knocked down, and cytotoxic T cells. Okay, that's acute fear. So They call it the standard of care. You and I know it's the standard of scare. Okay, they put you into a condition where you are going to agree to anything. Going to cut this off? Okay. Then you're going to burn me? Okay. Then you're going to poison me? Okay. All right. How many times have I had people come into me? I mean, I cry. I cry when I see what happens. I mean, people may think I'm over the top or hyperbole, but no. I had a lady with a lesion on her tongue. They took her tongue out. They took the right side of her jaw out. They irradiated her. She had no salivary function at all. She looked like a monster. They had to put a gastric feeding tube in her. And she wanted to stay alive because she had a young daughter. So her young daughter is looking at her mom. And although she loves her and hugs her, she still looks like a monster. All right? Had that woman known what she would have been going through, I don't think she would have agreed. Anyway, she comes to our center, and I just happen to have, as you all know, people come in. It's kind of like at labor and delivery, right? All of a sudden, you have a lot of women coming in that are ready to deliver. It's just like in CFC centers. I get 5 prostates, or I get 3 glioblastomas, or whatever. It's just like that. Anyway, when this woman came in, we had other people there, 3 other people with head and neck problems. None of them had surgery, and they were doing fine. Do you know how sad she was? Do you know how sad I was? Do you know how tragic this was? Okay, this is fraud by omission. There's fraud by commission, and there's fraud by omission. Commission, I tell a lie. Omission, I just forget to tell you the whole truth. All right, so here's the thing. The standard of care is that the patients have the right to know the diagnosis and the prognosis, even if so doing will cause distress. Okay? Patients' right to know so that they can make informed decisions. What? Okay. First of all, what's a diagnosis? Can you ask me what diagnosis? Dia, separate, gnosis means to know. How do you separate and know something? You give it a name. You give it a name, now it has existence. All right? Now, so we take a biopsy and we send it to the pathologist. They look at the histology and they describe the histology. Okay, this comes from a gland, adeno. It's a gland, it's a carcinoma, adenocarcinoma. Okay? All right, doc, is that it? Yeah, that's your diagnosis. Adenocarcinoma of the lung, huh? Okay, well, is that it? Yeah, that's it. But it fails to tell you 2 important things. What are the 2 important things that you want to know that you would expect would come from a diagnosis? How did I get this, and how do I get rid of it? Doesn't tell you that. If it doesn't tell you that, of what use of it is it? You could have called it a potato. Well, you could have called it anything you want, but we call it adenocarcinoma, and we got a big name for it, or invasive ductal carcinoma. Oh my God, what is it? Oh, it's in a duct. It went through the wall, so it's invasive ductal, and it's a carcinoma. Okay, yeah, and no, that's it. That's the diagnosis, and therefore your prognosis is what? Now, when they tell you if you don't do what they say, you're going to be dead in 6 months. If you don't do what they say, you'll be dead in 2 months. If you don't do what I say, you'll be dead in 1.5 years. You have to understand this is a lie. The reason it's a lie is because the people that don't do what they say, that never come back, they have no data on them. How can they tell you what's going to happen? If you don't do what I say, they don't know. All they know are the people that come back and agree to be in a study. The people that don't, they don't know. So for them to tell you what's going to happen, what happens to people that they don't know, is called a lie. But I guess if you're wearing a white coat, it's called a medical opinion, and it's okay, right? Okay. It's not okay. It's not okay. It's called sorcery, all right? I know I sound crazy, but I'm not. Because I've watched for 40 years people be destroyed, okay? Now, and withholding this information is a violation of their autonomy and trust. All right, first of all, they're so scared they can't make a decision. I won't go on. All right, so here's what the conventional is. It's disease-centered, okay? It views CFCs as the enemy, and the doctor is the general, and they have a military approach, and the nurses and technicians are the soldiers, and they go to war. They go to war against the tumor. Unfortunately, the battleground is the person's body, so that the collateral damage is their health and well-being. It's called side effects. It's not on the side, it's right in the middle. Let's call them middle effects, if we're going to call them anything. There's just other effects. Anyway, so that's the approach. It's a military approach, and so Richard Nixon, war on cancer. Ronald Reagan, war on drugs. And then the war on terror. Well, war never works for anything except for the people who finance it. We know that, all right? All right, so And this is a complete misunderstanding because I'd like to ask you, what is a disease? Okay, I say, okay, diabetes is a disease, right? What does a disease mean? It's a thing out there, outside of me. It's a third party thing that's going to get into me, and I've got to get rid of it. You have to understand the whole disease model is morphed from the germ theory. All right, they're out there. They're going to get us. Remember Rudolf Virchow, the father of pathology, the guy who wrote the book, first textbook on cellular pathology back in the 1850s, 1860s. He came up with all the words like anemia, Virchow's node. This guy was autopsies, all that. You know what he said? He said, if I had my life to live over again, I would devote it to proving that the microorganisms did not cause the mess. They're there to clean it up. Just like the flies did not make the feces. All right? Same thing. All right? So that theory, which was a theory, became the disease model, and that's conventional medicine. So diabetes, we got to get rid of it. Wow. If I'm eating pasta, bread, potato, rice, and cake, I've got too much glucose, so my body reflexively, as a homeostatic corrective response, becomes insulin resistant to protect me because I'm too stupid. All right, so I go to the white coats in the House of Horrors, aka hospital, and the white coat sorcerers say, you have a disease. We got to give you some poison. Okay. Does it go away? No. 40 years later, I still have diabetes, but now I have side effects from the medications, etc. Okay, so it's not a disease, it's a homeostatic corrective response. So what should I do? Let me stop eating the bread, pasta, rice, blah, blah, blah. There won't be glucose in my interstitial fluid. My cells will no longer need to go through that adaptation, and it's gone. These are adaptive responsive, and there's no such thing as pathology. That implies that something went wrong. Nothing can go wrong in this divine earth suit given to us by God or from God. All right, nothing can go wrong. It can only do what's necessary. It doesn't do anything else. All right, so we have to understand that. So what's going on is not pathology, but adaptive physiology. All right, let's not use their words, okay? Now, the standard of care. This is the face of cancer. Now, let's talk about health. Failure to meet your biological and psychological and spiritual needs is when you have to adapt. Those adaptations, the homeostatic corrective measures, are necessary to maintain functional integrity. Insulin resistance, I just gave that example. Hypertension, I'm eating pasta and whatever, it's greasy stuff. I get plaques in my arteries. I don't have the blood, but my body knows I need to maintain blood flow to the vital organs. How do you maintain blood flow when the pipes are narrow? You increase the pressure. Hypertension, we got to get rid of it. That's not the only cause of hypertension. I get that, but I'm just using that as an example. All right? It's not a thing that got into me that I have to get rid of. It's not a third-party demon. It's something that I can change by making sure that my body no longer needs to adapt. Same thing with CFCs, okay? Why are they fermenting? They're fermenting because they lost mitochondrial function. Period. Whether it's in your elbow, your ovary, your nose, whatever, it doesn't matter. That's what it is. All right, here is the standard of caring, the smile of health. This lady on the left, the older woman, had stage 4 colon CFCs, went to her liver, and this is her last day. She was leaving. That's her daughter. She had her hair, she had everything, she had her smile and all that. She left healthy and happy. Okay. All right. Okay. So health is our birthright. Okay. It's the optimal functioning of the organism. So if all biological, psychological, and spiritual needs are satisfied, what's the consequence? The mind and the body are centered in the ultimate spiritual nature that we are. Okay? So what do you have? You have unbounding energy and clarity. You have equanimity. You have joy, optimism, compassion, forgiveness. That's what you have. That's health. Right? You want to know what health is? Look at children playing outside. They can't sit still. Health is energy. Okay? All right. That's health. Okay? So, I just wanted you to understand that integrative oncology, when I started, didn't exist. I was really quick. I almost lost my license because I recommended fasting. Now, suddenly, I see in the bookstore, everybody's an expert on fasting and a urologist, and I just want to ask them, have you ever fasted? How do you know about this? Anyway, I've been doing this for 40, 50 years. Anyway, so the American Society of Clinical Oncology, ASCO, which is God, they have an integrative branch. Okay, the Society for Integrative Oncology has a branch. The International Organization of Integrative Cancer Physicians, which I helped founded, it no longer exists because someone died and now it's being reactivated. And then the Oncology Association of Naturopathic Physicians, and then another institute that I founded in Singapore, Institute of Integrative Oncology. So we're starting to get some legitimacy. All right? Now, how do we heal? Okay, 3 pillars and the bridge. We need to stop making CFCs. We need to target and eliminate them without harming the normal cells, and we need to awaken and enhance the immune system. And the bridge from the fear to faith is knowledge. All right. So I remind I tell the people that come, I don't like to call them patients. It sounds like they're passive objects that I'm fixing or something. Okay, these are students. Okay, so they come in and I say, okay, if you ever doubt it, I want you to go in the kitchen, get a little knife and cut your finger. And I want you to watch it for the next 3 days. And you're going to tell me what happens? It's going to heal. Try that with a Mercedes. Try that with a BMW. It's not going to heal. All right. So how do we, okay. So the body is like an aquarium. Think of it as an aquarium with 100 trillion, 37 trillion fish in the water. All right? Now, and they're sick. If you don't change the water in that aquarium, I don't care how much medicine you pour in all day long, they're still going to be sick. Okay? So you got to do that. And this is kind of in what our previous speaker was talking about. All right? We got to stop making it. If we don't stop making it, doesn't matter how good anyone is at getting rid of it, it'll be back. So when someone comes into me and says, I got this little mass here in my breast, and let me tell you something, if it doesn't grow and it doesn't spread, you'll live a normal life. So you're not really asking, how do I get rid of this? You're asking me, how do I stop making it? And if we don't address that, we've failed. Target without harm, okay? You got a thief in your house, you can throw a bomb, or get a mosquito, put some sleeping medicine in the mosquito, send the mosquito in the house, hit the target, and then the police will take them away, all right? That makes a little bit more sense instead of losing your whole house. Okay, those are toxic therapies. Now, metabolic therapies are when you understand the biology of CFCs, then all you have to do is put them in a position that they can't survive. High dose vitamin C produces peroxides. CFCs don't have a lot of catalase. They can't survive. Healthy cells do, so they turn that peroxide into water and oxygen, which is great for them. CFCs can't. Okay, that's a metabolic therapy. Okay, you got it? Now, the immune system, what we need to do, remember, it's the Department of Maintenance and the Department of Defense. Okay, if it's too busy with toxins, it doesn't have a lot of time for defense. All right? But, and understand about the defense. The microenvironment around the CFCs is, you can imagine this macrophage comes in there, it's ready to take a big bite out of that tumor, and it gets into the microenvironment, turns into a TAM, starts working for the tumor. Or if it's a natural killer cell, it just, okay, so that's what happens. We've got those 2 issues. So what do we have to do? We have to get rid of the toxins, and we have to change that tumor microenvironment. Okay, here's the thing. It's not difficult getting rid of CFCs. Go to the surgeon. He'll get rid of it. She'll get rid of it. All right? The problem is keeping them gone. They don't like to stay gone. All right? That's the problem. How many of my students come in, and it's their 3rd, 4th recurrence? All right? It's not a recurrence. It never went away. All right, so how do we stop? I'm not going to go over that today because today we're talking about the second pillar, targeting. I just want to give you a brief overview. Clean the body from mouth to rectum. That's the biological. Head to toe, lymphatic, everything. Heal the gut. Balance all hormones, all of them. I'm talking about pituitary, adrenal, thyroid. You can't just balance one of them. Okay, just like an orchestra, you're not going to tune up the woodwinds and not the brass and the percussion. Okay. Go to sleep early. Why go to sleep early? We happen to be diurnal, whether we like it or not, okay? Meditate as much as you can all day long. Read. When do you read? Read in the morning when you just first wake up. Meditate first, then you're going to read. What are you going to read? You're going to read things about truth. You're either going to read scripture or you're going to read things about health and healing and stuff like that. And in 15 minutes, you will read more and understand more than 2 hours at night when your mind is, you can't. You read at night for entertainment. Okay. You move all day. Every 90 minutes, set your alarm, get up, 10 minutes of vigorous movement. Okay. Eat human food at healthy intervals. 18-6, 18 not eating, 6 eating, or 20 not eating, which is ideal, and 4 hours of eating. All right. And if you're eating nutrient-dense food, you'll be fine. You'll be absolutely fine. Why do you want to have all that time? Now, if you stopped eating 4 to 5 hours before you went to sleep, so you can have good autophagy, right? And then you don't eat until 20 hours later, your fasting insulin will come down, all right? You will easily go into ketosis, okay? Yes. That's the way, right? One other way to go into ketosis, do a water fast for 2 days. You're there, all right? So, okay, in addition, periodic fasting, reconnect with nature, and stop lying. We all lie. We have to lie, right? We have to say, you like my blouse? Yeah, very nice. Okay, that kind of lying is not bad. But when we lie to a spouse, we lie to a boss, we lie to a friend, that is hurting us. And it's called emotional pus, all right? So we got to stop lying, all right? The best liars are the most successful. Remember Jim Carrey's movie with the lawyer? All right, so targeting, how do we do it? IPT, we can use chemotherapy or botanicals. That's the only toxin. Ascorbates, metabolic therapy. Methylene blue, photodynamic therapies, metabolic. Amygdalin, metabolic. DCA and LA, metabolic. Oxidative therapies from ozone to UBI, metabolic. Hyperthermia, artesunate, curcumin, quercetin. These are just some of them. I can't do them all. All right, now, metronomic chemotherapy, this is because doctors don't want you to know what they're talking about, and they don't want to use something simple like low-dose chemotherapy because everybody knows what they're talking about, and you got to pay them lots of money, so they call it metronomic. Oh my God, my doctor's doing metronomic chemotherapy. Wow, he must be really smart. I'm lucky. All right, metronomic, they got it from metronome. You ever took piano lessons? All right, and all they're doing is giving low dose at specific intervals. That's all it is. But it's actually low-dose chemotherapy. But we don't want to say that because we're doctors. But initially, they found out that what it did was low. It's almost like a homeopathic. High doses wipe you out. Low doses actually targeted the endothelial cells, stopped angiogenesis and other things. They thought that was the only mechanism. But it turns out that there's other mechanisms. Now, here's what we've done. And by the way, if you go to my website, drlodi.com, and you go to the podcast, you can look at. I've done several interviews with Dr. Donato Perez Garcia III, who's the grandson of Dr. Donato Perez Garcia. In 1918, started playing around with insulin, and he invented insulin potentiated therapies. What he did was, and go listen to those podcasts. What he did was, he said, insulin, So in those days, the most common admission to psychiatric hospitals, reason for it was tertiary syphilis. So what he did was they didn't have any poisons, any really good poisons in those days. They didn't have chemo, they didn't have antibiotics. So he took a little bit of arsenic, a little bit of mercury, insulin, and their tertiary syphilis went away. It was a big deal in those days. He was invited to the White House in the U.S. and all that sort of thing. In 1946, he treated the first person with CFCs with insulin potentiation therapy. Again, he didn't have chemo. He used mercury and arsenic. That lady in 1946 saw his grandson, Donato III, in the mid-90s for some other reason. Okay. Anyway. IPT predates chemotherapy. By the way, what does that do to clinical trials? It shines the light on what they are. They're just money makers. This is indicated for ovarian. Well, now we can use it for breast. Now we can. It's poison. You get poison in the cell, and you can get it in faster than it can get out. The cell's dead. All right. That's what insulin does. Insulin opens a door that the cell can't close because it needs it for survival. So I used to have, when I first started doing this in 2002, I had oncologists would say, they would use all the protocols and it would fail, and they would say, go see this guy, I don't know what he does, but it works. So they come and see me, I took the last protocol they were on that failed, I used it with insulin and 10% and it worked. Okay, here's the thing, 10% dose. Let's say 50% goes in the CFC and 50% goes to the body. That's 50% of 10%, which is 5%. So the side effects are 5%. You don't lose your hair, you're able to go work, shopping, and eat, and you're happy, okay? So you can get the same benefits. In fact, we're finding that you get the same concentration in the tumor that you would have got, or higher concentration in the tumor than you would have gotten had you give maximum tolerated without insulin. Yeah, all right. Why? We have all these insulin receptors. CFCs have 6 to 17 times more insulin receptors, and these insulin receptors have a 70% higher affinity for insulin, and they're resistant to downregulation. So these guys are serious about getting that glucose. How do you compete? You stop eating for 18 to 20 hours, right? So that your fasting insulin comes down, so that your cells are now insulin sensitive, not insulin resistant, and you can compete. So when you sit down to eat, they don't eat first, the CFCs, you all eat together. And guess what? That's relative starvation for them because they need 19 times more glucose. Anyway, here's some study. Human breast cancer cells have 6 times more insulin receptors and IGF-1 receptors. By the way, insulin-like growth factor 1. Here, normal tissue, fibroadenomatous tissue, breast CFCs. You can see the density of insulin receptors. In fact, what happened here? That's not showing me what I wanted to see. Okay, yeah. By the way, it's the CFCs produce their own insulin and they produce their own IGF-1 because they don't want to have to deal with systemic balances. They need it. All right. So autocrine. All right. Why do they want to produce insulin? And why do they want IGF-1 receptors? Because insulin has a 43% homology with the insulin receptor and the IGF-1 receptor, 43% homology. So insulin can stimulate IGF-1. Oh no, that's going to make it grow. Yeah, it makes it grow. What it does is it puts it into a G0 phase. So what happens? Now it's vulnerable. Now it's more vulnerable and it will more likely be eliminated with the chemo. All right, so if you can paralyze it, right, and that's what it does, it paralyzes them. So in a normal tumor, about 1/3 of the cells are actively dividing, 2/3 are quiescent. When you give insulin, which stimulates IGF-1 receptors, 2/3 are now actively dividing. All right, so that means they're more susceptible. Number of insulin receptors on C is much greater. The insulin receptor count correlates with tumor size and histological grading. Do you realize if we just looked at that, we wouldn't even need to do PET scans? All right? Okay. And as I said, the binding capacity and affinity for radio-labeled insulin was found to be 9 times greater in breast CFCs than normal. And they don't downregulate. Okay. Now here's the mechanism. How can that do it? It's like this. I want to show you. All right. One of the main fatty acids in our cell membranes is stearic acid. It's a saturated fatty acid. Its melting point is 68 degrees centigrade. Body temperature is 37. All right. You give insulin. It stimulates an enzyme called delta-9 desaturase, which turns that stearic acid into oleic acid. It puts a double bond at the 9 position. You wind up with trialine or oleic acid, olive oil. And what happens? Its melting point is now 5 degrees. Which means it's fluid or permeable at body temperature. That's on purpose. God did that on purpose. Yes, absolutely. So oleic acid. So when we eat, I guess we're all Italian, right? We all turn into olive oil. Up. All right. Oh, here it is. Yeah, look here. Well, it even looked at, well differentiated, poorly differentiated, moderately differentiated. Node status and tumor size all correlate with insulin receptor density. Okay. Here's the homology. I've shown you this, the homology between insulin receptor and growth hormone receptor. All right, just to show you, they give methotrexate with insulin, without insulin, and you can see you're getting the same effect with less and less and less chemo. Same thing for doxorubicin. Okay, ascorbic acid is these two, you see on the bottom there, those two little OHs there, that's the action, all right? By the way, the difference between a corpse and a living body is redox biochemistry, period. All right, physiologically, that's what's happening. As long as you can exchange electrons so that you get electrons. By the way, we're talking about photons and light previously. Light is, I'm talking fast because I got to finish. I only have a small amount of time. Okay, light is no mass, no charge. It's pure energy. However, it hits a plant, and what happens? It gets turned into electrons, which have mass and they have charge. So electrons are the children of light. By the way, Einstein didn't get his Nobel Prize for relativity. He got it for the photoelectric effect, right, which is what we're talking about. So light becomes electrons, and that becomes the energy that fuels all life, right? And that energy, if you want to know, are we electrical? Do an EKG, and you'll see that we're electrical. You get a flat line, you got problems. All right, so ascorbates. Now, almost all organisms produce ascorbate because it's part of the fundamental redox biochemistry. All right. Now, some of the non-photosynthetic prokaryotics don't, like zooplankton, right? Don't. A few don't, but the rest all produce ascorbate, right? Including fish, amphibians, reptiles, and most mammals. They produce it because it's necessary for life. All right. Now. Why don't we produce it? Because we lack an enzyme called L-gulonolactone oxidase. However, if we had time, I would tell you how that might not even be true. Anyway, check it out. Glucose, vitamin C. Okay, why? Because vitamin C is a derivative of glucose. All right, it's part of carbohydrate metabolism. All right, very, very close. Which is why if you got an IV vitamin C and you get in an accident and you go to the ER and they do a finger stick, they're gonna say, "Oh my God, his glucose is 300. Let's give him some insulin." All right, physiology of ascorbate, just real quickly. Okay, we can only absorb sodium ascorbate. Sorry, sodium-dependent vitamin C transporter systems, 1 and 2. That's it. So you give someone ascorbic acid, guess what has to happen? It has to drop the hydrogen and find a sodium to get in the door. It's got to drop the hydrogen and find a sodium. So just give them sodium ascorbate so you can skip all that stuff. Make sense? Yeah. Now, the other way you can pick it up is when ascorbate arrives at a tumor bed and it goes into that tumor microenvironment, it gets oxidized and becomes dehydroascorbic acid, right? That is recognized by the GLUT1 receptor. By the way, the GLUT1 receptor is upregulated in a lot of CFCs. So it picks up that DHA, the DHA goes up into the tumor cell quickly reduces it using all of its using its catalase and its thioreductase and stuff like that. So it uses it up to turn it back into ascorbate. Why is that important? Because if you've got a continuous flow of ascorbate because you're getting enough in your diet, then what happens? That tumor cell is losing its antioxidant capabilities. It becomes more vulnerable. Very, very important. The other thing is that ascorbate is necessary for the dioxygenase enzymes. They are, number one, they are how HIF-1 alpha, you all familiar with that? You get hypoxia, it stimulates these factors, HIF-1 alpha, which is how tumors grow, angiogenesis, tissue proliferation, etc. The off button is the oxygenases, which require iron in its ferric, not its ferrous state, and that is kept there by ascorbate. So if you look at someone's HIF-1 alpha on admission or in your thing, and you look at their fasting ascorbate level, you'll find the HIF-1 alpha is high, ascorbate's low. If you can get that reversed, you won. Okay? Very, very important. The other thing the oxygenase enzymes do is they run around and they look at all the different epigenetic expressions and they rewrite it. They take off all those methyl groups, okay? They take them off. They restore the epigenetics back to the original, which is great. Why? Because now if the stem cells that come from there won't be CFC stem cells. Very, very important. So that's what just having normal physiological. So when you're going to get IV vitamin C, should you sit down and get IV vitamin C twice a week, 150 grams? No. Why? Because the first thing that's going to happen is it's got to fill up the deficit. So instead of doing that, then you might reach or you might not reach 350 milligrams per deciliter, which is the plasma level you need to kill CFCs. So what do? You make sure you're taking 2 grams of sodium, liposomal sodium ascorbate 4 times a day. You're doing that every day. All right, or you put 8 grams. You can only absorb 200 milligrams, 300 milligrams of ascorbate in your gut. Otherwise, then the rest comes out in your urine. All right, so you can do that and or take that. So if you're doing that and all your physiological requirements are met, now you sit down and get an IV of vitamin C. Guess what's going to happen? No deficit. It goes straight up to being oxidative, and you might only need 50 or 75. Do doctors measure whether or not their person has achieved what they were hoping to achieve with the? Usually not. They don't measure that. It does everything. It restores TH1 and polarity. It recycles. If you knew what this stuff does, you'd say you'll never go another day without taking it. All right. Anyway, it makes L-carnitine. Blah blah blah. Okay, let's go. Anyway, how much do we need? All right. So you want to have a fasting ascorbate level of 50 micromoles per liter. Okay. Now, which comes out to what? 2.0. That's not a lot, but that's to maintain, that's to be healthy. If you get down to less than 23 micromoles per liter, then you've got a hypovitaminosis, and if you get that less than 11, you're scorbutic, meaning you're going to get end-stage scurvy. There was a study done with 200,000 Germans, and they found out that 40% were scorbutic. 40%, that's sausage and beer, Okay, so anyway, we'll go. Cytotoxic. Anyway, I can't do it all. All right, so what does ascorbate do? It's a pro-oxidant intracellular redox stress, right? Because remember the DHA is picked up. It downregulates the hypoxic phenotype, which is what? HIF-1 alpha. What else does it do? It's got epigenetics. It restores it. It also decreases EMT, epithelial mesenchymal transition, so that the stem cells, you can't turn mature cells into stem cells, and it enhances immunity. That's just if you, okay, other than the pro-oxidant effect, all this other stuff comes from just getting enough of it. All right, here's the famous Fenton reaction. You know, the ferrous becomes ferric. Ferric becomes ferrous, right? So what? This is the storage form of iron. This is what you find in spinach. And if you don't have enough hydrochloric acid in your stomach, you won't make that conversion and you won't be able to store it. All right? And then you wind up with peroxides. That's it. That's the Fenton reaction. That Fenton reaction is how our, by the way, the other thing I didn't mention is that our neurotransmitters require ascorbate. So if you don't have enough ascorbate, you're not going to be making epinephrine, serotonin. Okay, we're taking all these serotonin reuptake inhibitors for depressed people. What if they don't have enough ascorbate and their gut microbiome is not working? Well, there's the reason. Okay. Anyway, HIF-1, I won't go into that. Yeah, it restores the epigenetic thing. Okay, and here's all the ways at which the epigenetic changes that it does. Right, look at that. It upregulates p53. It does all that stuff. If I'm just taking enough, do you realize if you were taking enough of it, you might not ever get CFCs? All right, curcumin, right? If you went to God and said, "Hey, God, we're having a problem here on planet Earth. There's a lot of CFCs going on." He said, "Can you help us out?" And he'd say, "I already did. I gave you curcumin. What are you talking about?" All right. What does it do? What doesn't it do? It does everything you want it to do. All right. Now, by the way, the problem is if you take it orally, you can only absorb 3%. If you take it IV, it gets metabolized too quickly. So there's a oncologist at Lenox Hill in New York City who's giving intravenous liposomal, which escapes the metabolism and gets to the tumor. Isn't that amazing? I tried to get some from him, and no, I can't get it. So if you guys know of any compounding pharmacies who can make a liposomal, a good quality for IV, it's a big deal. We need to get it. Okay, but look at all the stuff it does. Curcumin. Okay, here's what it does. Just a few important things. If there was a drug that did this, it would be $1 trillion seller. Check that out. What? Yes. Okay, no drug does that. And again, this shows you that nature doesn't have lycopene trees. Nature doesn't have individual isolated nutrient trees. Nature gives us a tomato, which has lycopene and everything else. And that synergy is required for health. Not we think, oh, let me just get this. No, you can't do it that way. Just studies, I just want you to show that curcumin also inhibits HIF-1, which is the fundamental way in which tumors progress, right? That stimulates their growth. Quercetin, same thing. It's a flavonoid, okay? We get that in green tea, onions, apples. What, you mean from plants? Okay, anyway, anti-proliferative, cytotoxic, binds to ER beta. By the way, if you're ER positive and you have an ER positive breast CFCs, that means your ER alpha you have more of them, all right? So estradiol, estrone bind to that weakly to the beta. On the other hand, estriol, the predominant estrogen during pregnancy, binds predominantly to the beta and just a little bit to the alpha. So what does that do? Beta shrinks tumors. And also binding to the alpha means it's weak alpha, but the net effect is beta, which is shrinking the tumor. So now what happens? Because it's sitting on the beta, estradiol can't go there, and estrone can't go there. So it's basically doing what tamoxifen claims to do, and that is it's blocking. It's a blocker. At the same time, it's doing that. What else does that? Soy. Don't eat soy. Oh yeah, don't eat soy. Okay. First of all, the Japanese, for as long as we've been measuring, have lived 10 years longer than all of us, and they eat soy all day long. So how could it possibly be bad? It's not. All right. But anyway, so it's an ER beta. So is flaxseed. ER beta, beta, beta. You want to get beta. So is prostate CFCs. Where else do we have estrogen receptors? On our lungs, colon, pancreas, kind of a lot of places. Yeah. Whoops. Go. Here we go. All right, here, what was this? This was, oh, artesunate. You all know artesunate comes from the wormwood tree. This and the ivermectin both won the Nobel, were awarded the Nobel Prize in 2015, right? And basically, artesunate from wormwood, what it does, it's effective against malaria 100% of the time. What it does is it seeks out iron. When it finds iron, it produces an epoxide bridge, and it destroys, it electrocutes the malarial organism. Well, guess what else has a lot of iron? CFCs. They need iron to multiply quickly, all right? So that's why when you do blood tests on people with CFCs, you're going to find that their iron is low and their ferritin is high. And in fact, if you have someone who doesn't know they have CFCs and you find out that their ferritin to iron ratio is 5 or greater, you better do a PET scan. Okay? Telling you. All right. Now, so anyway, that's what happens. The tumor is grabbing the iron. The body's saying, wait, and is storing it in the ferritin, and there we kind of got that high ratio there. All right. Now, so artesunate works very well. The problem is it gives you anemia. You get anemia from it, okay, because it goes into the red blood cells too. So this study here found that if you do it on day 1, 8, and 21, it works. I'm still trying to find the best way to do artesunate and not cause anemia. All right, so but it's a very, very important thing to do. Talk about intratumoral injections. That would be the thing to do. Inject it into a tumor. That would be fantastic. Yeah, okay, so breast CFCs have 5 to 15 times more transferrin receptors because they need more iron, right? Leukemia has up to 1,000 times more transferrin receptors, so they need iron, okay? So that's what they do. So that's why the artesunate works. Okay, here's just a pictorial. You can see that the healthy cells have less iron receptors. CFCs have more iron receptors, more insulin receptors. They've upregulated beta glucosidase. There's all sorts of changes they had to make. They lowered the P53. They did all these things so that they could survive on fermentation. That's why they exist. Okay. Lymphoma, myelomas, just same thing. Studies. Now, the other thing I give is DCA. Now, you might have heard of a familial lactic acidemia. These children are born, they have a defect, they can't seem to get into the mitochondria. So they wind up producing, going through fermentation, glycolysis, and they have a lot of lactic acidemia. So it's familial lactic acidemia. These children wake up in the morning, they feel like they just ran a marathon, they can't go to school. They give them this simple molecule, an acetate with 2 chlorides, and it blocks this. Can you see this? It blocks this enzyme, which would normally block this enzyme, therefore allowing pyruvate to going into the mitochondria instead of going to forming lactic acid. So guess what happens? These kids can go to school. Am I done? Is that what you said?
The time is
Hey.
up. No worries. You can carry on at this
Yeah,
point.
please let me just. Okay, so anyway, a DCA is amazing. You take it orally. So what I recommend, 5 milligrams per kilogram. Start with that a day, and then you go up until you start to get a perioral numbness, and then back off because you want to know what makes you. So you back off so you don't get that reversible paresthesia. Now you know you're getting enough DCA. Also take ALA, 300, 400 milligrams 3 times a day. ALA makes the DCA gets the pyruvate in, and the ALA makes it so it has to stay in. Those two together are going to cause the CFC to starve. Very, very good. Very important. Dichloride. Yeah, it's just studies on that. Fenbendazole, mebendazole, all the benzimidazoles. Why do they work? Well, they go after microtubules, but they do other things. They kind of go after all of the different and block the different pathways of CFCs. All right. So, but so does ivermectin, and so does niclosamide. In fact, niclosamide is now being used as frontline therapy for ovarian CFCs. I mean, and it works with sarcomas. Why do these anti-parasitics work with tumors? Could parasites have a role in there? You mean Royal Raymond Rife might have been onto something, getting 100% people cured? A guy named Dr. Weber in the 1970s at the Max von Heffenhofer Institute in Munich. All these people are seeing stuff with a high-powered microscope. You can see these nano-sized guys in there doing stuff. Doxycycline, minocycline, we'll get them. Mebendazole. Mebendazole not only is like fenbendazole, we all know Joe Tippins. Not only that, but mebendazole has been shown to kill the CFC stem cells as well. So ivermectin kills CFC stem cells, mebendazole kills them, niclosamide kills them, vitamin C kills them, curcumin kills them, and doxycycline. All of them kill the stem cells. Kind of good. And in fact, the combination, if you look at the study of curcumin and vitamin C, is 100 times more effective than almost all the other. Here's ivermectin, blah, blah, blah. It does the same thing. What does ivermectin do? Inhibits tumor cell proliferation, it stimulates apoptosis, inhibits angiogenesis, modulates the tumor microenvironment, right? It suppresses Tregs. Tregs shut off activated T cells. Wow. And it's suppression of metastasis. It prevents epithelial to mesenchymal transition, which is where a mature CFC turns into a stem cell and can metastasize. It does all that, ivermectin, okay? But don't ask Fauci about ivermectin. Yeah, there you go. There's a study. Shows you that. There's a study. You can look at the study up, 2017. Whole body hyperthermia. We were talking about William Coley. William Coley gave attenuated or serratio marcescens and strep pyogenes, induced fever continuously 2-3 weeks, and it was gone. How long was it gone for? It's the only study. It's the only therapy we have in our history of oncology that has 30-40 year follow-ups of sustained remission. What was it? Fever, an endogenous fever. Produced the fever. Because what does that do? We'll never know. All the things it does. Dr. Kobayashi Tsuneo, I worked with him for 30 years, 20 years. So sad he died recently. And I could have helped him, and he didn't tell me that he had cirrhosis. And it wasn't from drinking or anything like that. He got it from some plant or something. Anyway, he was doing the same thing with something called PC Banil in Japan, and they kicked him out of the hospital because it was too excessive. It was too successful. So when he went to his clinic, this guy was a biochemist first, then an MD, and then an oncologist. So he was a PhD MD, not an MD PhD. So everything he did had to be proven first. So here's what he did. And someday I'd like to tell you about his TMCA, but anyway. What he did is he says, okay, external heat is not the same as endogenous fever. How can I reproduce it? Anyway, I don't know how he came up with it, but he figured out that the cyclic AMP ratio to the cyclic GMP ratio in healthy cells is opposite in CFCs. So how does he, so that's the fundamental bottom line. Can you imagine that? And what is cyclic AMP? It does everything. It's just like a messenger. I don't know how he figured it out, but he did. Anyway, so he during a whole body hyperthermia session, which is 6 hours, and you get, anyway, I studied that. It's not done in Germany or anywhere else. Anyway, for that, he drips in dibutyl cyclic AMP, and he puts in a phosphodiesterase inhibitor to prevent it from converting, and he keeps the cyclic AMP to GMP ratio he keeps the temperature at 40.5 or 41. Why? Because that stimulates heat shock proteins, which stimulate mitochondrial biogenesis. And what happens is you turn a CFC back into a healthy cell, because if a CFC now it's full of mitochondria, it's no longer by definition a CFC. And amazing, here's a Buddhist in Japan. He gives me a Christian metaphor. He says, think of it as the prodigal son. You don't want to kill it, you want to bring it home. Okay, I love it. So mitochondrial heat shock proteins, there we go, heat shock proteins. Biological dentistry, oh my God, I don't know when the mouth left the body. I still haven't figured that out, but we don't look, right? When you learned how to do physical exams, what do they say? H-E-E-N-T. What about the O? What about the MO? No, we didn't learn about the mouth. Anyway, here's the thing. No metals and nothing dead in the head, all right? Root canals, here's the chart. You guys got to know about this. You got to get if you don't do biological dentistry, if you don't evaluate your students' oral situation, if you got a root canal on a breast meridian, and it doesn't matter what you do, doesn't matter, you got to do it. All right. So here's what they use in biological dentistry. All these things, everything. It's amazing. Okay. Now, okay, now last part, oncoimmunology. All right, we use GC-MOF, IL-2, cytotoxic T cell, dendritic cell vaccines, natural killer cells, systemic hyperthermia, mushrooms, and all that stuff. Meditation, just studies showing you that meditation works. Talking so much, but anyway, peptides are, 100 or more amino acids is a protein, less is a peptide. Okay, peptides, we make 300,000 peptides in our body. All right, a lot of them are hormones. Anyway, it turns out that there's two very important ones. You've got anyone who's over the age of 40, they're going to need thymosin alpha 1. Our thymus gland involutes, all right? You're at about 20% at 50, and at my age, I have no I have no thymus. Okay, so how does the thymus do it? It produces a 28 amino acid peptide. That peptide matures T cells that are born in the bone marrow into healthy T cells. So now I can have T cells. So why do elderly people lose their immunity? Three things. Number one, they lose their thymus gland. Number two, melatonin goes down. And number three is I forgot right now. I'll remember later. I told I'm trying to hurry. Anyway, TA1, that's the one. TA1, thymosin alpha 1, 28 amino acids. You need it, you need it, you need it. You inject 2 milligrams daily for at least 6 weeks, all right, to bring up and then you can do it every other day for a while, after a while. And how long should you do that? Well, as long as you want to have immunity. Here's studies on it. By the way, it was FDA approved in 36 countries until they found out it helped with the great hoax of 2020. Remember the great hoax of 2020? It helped people that had COVID, and so then it went into the same bag as ivermectin. Bad, bad, bad. So now in the United States, you can't make peptides anymore. Unbelievable. This is the other one. This is the big deal. This is methionine enkephalin. It's a 5 amino acid peptide that's produced in our brain, our spinal cord, our sympathetic ganglia, and the adrenal gland. All right, what does it do? It normally mediates between the neuroendocrine system and the immune system. But when you give it in this situation, it goes into the tumor microenvironment and it does everything that was shut down. It activates NK cells, it activates macrophages, and it brings them back to the M1. It downregulates Tregs. It does everything. In other words, it reverses the immune suppression by the tumor microenvironment. And that is what the wall you run into if you're treating people with CFCs. The wall you run into is that tumor microenvironment. And whatever else you do, as soon as it gets there, they get paralyzed. So if you can change that and you can restore T cells by giving TA1, you're gonna do well. But of course, what's the king of them all? Meditation. Meditation trumps everything, and I don't mean Donald Trump. And there's all kinds of studies with this. You can read about it. Methionine enkephalin, MEA, 5 amino acids. PNC27, the last one. It binds to HDM2 protein on the cell surface of only CFCs. It's only on CFCs. When it binds to it, it produces a ionophore, a pore, and the cell dies. So what's the big problem with this? If you do, you wind up getting tumor lysis syndrome. So you just keep measuring uric acid. If it starts to go up, you slow down on it. This will target and destroy. It's a peptide. And the end. Target the CFC, not the person. Promote healing, restore immunity, and let the person eat, sleep, and laugh, because we don't know if any of us will be alive tomorrow, right? Right. All right. Thank you.
What an incredible session there, Dr. Lodi. Everyone had been desperately waiting for this, and I would like to see the audience actually tell what does it feel like. How was it? I think I've seen all the expressions coming in from the entire team that they had been trying to express all this want. We want more is coming in. Nobody wanted you to stop, Dr. Thomas. So it's it's really difficult for me to actually do anything at this point. Dr. Garg, would you like to say something? I can bring you on the spotlight. You can maybe explain what the participants have been saying all this time.
I think this is fascinating, and we would like Dr. Thomas to conduct more sessions for us in the future. And I think he's open and he's so kind.
Yes,
Yeah,
yes.
I'd love to.
Thank you, Dr. Thomas. Very, very interesting. And you completed it in, the little time you had, I think you touched every spectrum of treating cancer.
Yeah, I tried. Thank you. Yeah. No, I want to be part of this group because I really want to eventually do most of my work in India. That's one of my goals in life. So.
Looking forward, Dr. Thomas.
You're already a part of us. We love you already. India definitely loves you, no doubt about it. So already a lot of people had been waiting for not only for your session but for your sessions coming forward. So probably we will be planning your sessions coming forward. So I'm pretty sure participants will be very, very excited about knowing this, that we will be planning to organize sessions for you coming forward.
Yay.
And with that, if you want, I can take, so people are looking for your thoughts quite a bit. So Dr. Thomas, I'm just going to quickly take in a couple of thoughts that people are looking for. So what's your view on HBOT or cryotherapy in cancer treatment?
HBOT, very, very important. And if I had the clinic of my dreams, I would have people do it at least an hour a day. Very, very important. But in a chamber that is comfortable, where you're not paranoid in a little cocoon, a bigger chamber, so that, yeah. And then cryotherapy, if it's done, it's an interventional radiologist, knows what they're doing and does it the right way, it's excellent. If it's done the wrong way, you can cause problems. So yes, it's like everything. You got to have the right person doing it. Yeah.
And one more there. What are your thoughts about turbo cancers caused by the recent famous wax? How can people stay
Yeah.
ahead of that?
All right. Okay. There's so many unknowns. When I have some friends in Europe, I have an oral surgeon, very smart people. They're looking at what they're taking, Moderna and Pfizer, looking at the vaccines. They see no mRNA and they see no spike protein. What they're seeing is synthetic biology. They're seeing these things move around. Boiling it, putting poisons in it doesn't stop it. They put it in the Faraday cage, it stops. Now, on the other hand, we got Peter McCulloch and people in the US who do see mRNA, who do see spike protein. So I think this was a grand global clinical trial, and they had all different arms. And so we don't know what we're dealing with. What I would say for sure is, one thing we do know is that if the spike protein is involved, nattokinase has been proved. There's several papers on it. Nattokinase will actually eliminate the spike protein. But other than that, the turbo cancers, whatever it's doing, and we don't really know yet, you still have to do the same thing that you always do, and that is clean the water in the aquarium continuously. All right, that's colonics, lymphatic work, going to sleep early, meditation, prayer. Eating real food, and move around. Do all those same things. Do targeted therapies and all that. So live healthy, because remember, there's only one way to get health. That isn't that amazing? There's only one way. How do you get health? How do you find health? By living healthy. There's no other way. Can't buy it. Can't negotiate it. Can't demand it. Got to live healthy. You got to earn it. It's like respect.
Wonderfully said. I don't think I really have any more words to add in. And we are all pretty much awaiting to see you, not only online, but offline as well. Looking forward to seeing you soon, Dr. Thomas. Thank you so much for your valuable time, both the days.
Thank you.
We
Namaste.
absolutely
Namaste.
enjoyed. Namaste ji.